Hi, welcome to this fascinating seminar, Swab for COVID and Screen for Cancer, all about the issue of cervical cancer in the time of the pandemic that we're so engrossed in. No doubt many of you are like us, in lockdown. We sincerely sympathise with you. I'd like to begin by acknowledging the traditional custodians of the land on which I happen to be, which are the Wurundjeri and the Wurrung of the Kulin Nation, to pay my respects to their elders, past, present, and to their emerging leaders as well, and to, I guess, encourage us all to learn much more about the traditional custodians of the lands where we happen to be. From the university's point of view, then the university records its deep regrets for the injustices suffered by the Indigenous peoples of Australia as a result of European settlement, and in particular what the university has done, that it also acknowledges and sincerely regrets any past wrongs carried out in the name of the university, which have caused distress to Indigenous Australians. There's a really interesting account of the history in Naarm in Melbourne. I look up wurundjeri.com.au because reading the history is an incredible lesson for us all. Welcome to you all, and thank you very much to the Melbourne Population Global Health Student Society for organising, the fabulous team that have got this going, and we have 5 wonderful panellists: Christine Walters, Jane Leong, Tim Ross, who's just joined us. Tim, welcome. Marianne Saville and Setyana Marti Dewey. So we'll get straight into it, if that's okay. What we'd like you to do is to ask questions on the Q&A. You can also use the upvote if there's a question there that you like and you'd like to see that. Then we'll ask each of them to be speaking for about 5 minutes and then throw to you to respond to your questions as much as we can. So again, we're delighted to have our panelists, and our first cab off the rank is Christine, who happens to be way up north, north of Toowoomba. You know, Christine, we're so lucky to have her. She's going to talk about her lived experience with cervical cancer. She's become an incredibly out there ambassador and lived experience speaker with the Australian Cervical Cancer Foundation, and she'll be speaking about her own experience with cervical cancer, her journey through diagnosis and treatment, and the impact of the pandemic as well. Christine, thank you so much. We look forward to your talk. Thank you.
Thank you very much, Rob. Yeah, I think I need to go back to where my story started, which was right back in 1998 when I moved from New South Wales to Queensland to go to University of Queensland. And I had gone for a pap smear, and all of a sudden I got a phone call and I had to go in, and I had abnormal cells, and I honestly can't tell you what level they were at, because at that stage I hadn't been in Australia for so long and I wasn't quite understanding of what was going on. I just knew that I had to go to the hospital and have a cone biopsy. And when that happened, it was quite traumatic. Obviously, I didn't have any family in Australia, and I was very diligent afterwards, and I didn't have any symptoms or anything wrong with me for many, many years. And then we kind of fast forward to 2013. I am married now. I'm 47 now, but I'm married 11 years. And at the time, my husband and I had been trying to fall pregnant for about 3 years. And after going through a barrage of tests, I fell pregnant on the second AI cycle. And, you know, we were super happy, and everything was going well up until the point where I was going into labour and I couldn't dilate, and the doctors couldn't work out why, because I'd had so many tests and everything was saying that I was fine. And then afterwards, after we ended up having an emergency cesarean, my whole, you know, everyday life was consumed with having a newborn. And so little symptoms I was getting, I was ignoring it because I put it down to having a baby. So I was getting intermittent bleeding, intercourse was very painful. I was very fatigued. I had a sore back. But all of that, as a new mum and first-time mum, you would just kind of go, well, it's probably just from having a baby. And because I was as fit as I had ever been and felt great, apart from those little niggly things, I wasn't too worried. When Mia was about 6 months old, my husband and I said, we need to get this checked. And I booked in for a pap smear with my own GP. And the night before I was due to go, I hemorrhaged and I lost over 1 litre of blood. And we raced to the ER, and I had a lot of people telling me I'd had a miscarriage. And I said, no, I have not had a miscarriage. I wasn't pregnant. But there was no one that actually looked at the whole overarching symptoms I had. Everyone was very focused on the blood that I had lost. And when they couldn't work out what it was, I got sent home because they said, you haven't got a temperature, you're not sick, so you go home. Come back if you get bloated or you're in pain. And the following day, I looked like I was 6 months pregnant again, and I was in a lot of pain. And my husband drove me back to the ER to once again be sent home because I didn't have a temperature, and got told that I would have to book in with their gynecology department in about 3 weeks. And at this point I went, I'm going to book in with my own gynecologist. He said, look, this is probably a 5-minute procedure due to the fact that you've had a really big baby. So a bit of diathermy, which is cauterizing some blood vessels in my cervix, should do it. And after the 5 minutes passed, he was looking more and more serious. And at 45 minutes, I am still having biopsies taken of my cervix. And I left saying to a friend of mine, I think I have cancer. And the next day he rang me, which is obviously very, very, what do you say? It's not normal for a doctor to ring you at home to let you know your results. But it was that critical that he got a hold of me, and he said, look, you and Neil need to go and see a professor of gynecological cancers. I have made you an appointment and you must go. And I'm asking him, how serious is this? And he said, look, I think worst case scenario, you will need a hysterectomy and maybe a little bit of chemo and radiation. And so when I came in there, I remember sitting with my husband and with Mia sleeping in a bassinet and looking at all these women who were bald and looked very, very ill. And I said to Neil, I said, this is not me. I said, I'm healthy as an ox. I have, I don't feel sick. There must be a mistake. They must have really got my results mixed up with someone. And the next thing that's crystal clear is I'm in the office with the doctor, and he looked at me and he said, look, unfortunately, you won't be having any more kids. And that was the one thing we were dreaming of, having another baby. And I said, oh, do you have to perform a hysterectomy? And he said, no, it's too late for that. Your cancer spread. And I said, well, what do you mean it's too late? He said, you are right on the verge where we can't save you. So then we basically entered sort of what I would call battle stations. I went and met with a chemotherapy oncologist, a radiation oncologist, and I started treatment basically straight away. I had to enroll our daughter into daycare. I had to wean her all within 2 days. And all these things were things that were basically out of my control. I didn't want to wean her at that point in time. And so, I felt like a burden to my family. I felt like a horrible mum, but everything was happening so fast. And I entered 6 weeks of radiation daily and weekly chemotherapy, and I was so sick. And after that, 3 weeks of a little bit of a gap to kind of get your health back up, and then I went into hospital to have brachytherapy. For those of you that don't know what brachytherapy is, it's literally 3 metal rods that get inserted into your vagina and uterus and cervix, and you are in isolation. You are laying down for 3 days. You can only have 15-degree incline on your bed. And for 10 minutes every hour, there's an isotope, radioactive isotope that pulses radioactive beams or internal radiation on your tumor. And so you literally lay there for 3 days, and it's possibly the most awful thing that I have ever gone to. And I remember saying to Neil, look, you cannot be a minute late when you come and pick me up Sunday afternoon, because I cannot do any more of this. It was so hard, not the radiation, but your whole body is telling you to move and you can't. And at one point I actually threw up from pain, and it was right at the beginning of my 10-minute radiation, and no nurse could help me. And because I couldn't move, I ended up sitting holding the dish with, excuse my word, but with my vomit, and it had gotten on my face. And I remember feeling utterly humiliated by my own disease and my weakness of not being able to fix myself. But we got through it, and 8 months later, after all the different treatments, I also partook in a trial to make sure that I didn't get any metastases. But 8 months later, I was declared cancer-free. And everyone said it's a miracle. 2 months later, I started feeling sick again. And by this stage, my chemo-oncologist was on maternity leave. So I saw my radiation oncologist, who told me that I possibly had survivorship guilt and I should just go home and, you know, it's all in my head. And I said, look, it's not in my head. Something is not right. But I got brushed off, and 3 months later went back for a second checkup. And I said, look, I'm really sorry, but there's something really wrong. And before I knew it, I was back in the PET scan and back in with Professor Obermeyer, who told me that, look, we can't save you this time. Your cancer has metastasized to your mediastinal lymph nodes around your heart and your lungs. And I said, how long have I got? And I said, he said, look, you're lucky if you've got a year. And so this is in 2015, nearly a week to the date that I was initially diagnosed in January, the year previous. And I just said, look, you need to give me, or try to give me, the time that I need, that my daughter can remember me. I don't want her to only remember me based on what other people said that I was like. I want her to know me as a person. And I said, I don't care what I have to do to get there. So I basically entered what I call the fight for my life and of my life at that point in time, and went through another round of about 1.5 years worth of chemotherapy with a drug called Avastin. That was quite harsh as well. And then when my body couldn't take anymore and my metastases came back and it popped up in other areas, I was very lucky to be able to get onto some immunotherapy. Although it's not on the PBS, I fully credit that and my chemo-oncologist for saving my life, because it was within the first 2 weeks of me getting on immunotherapy that I started feeling like a human again. I could go, I could drive, I could go and see my horse, I could be the mum that I wanted to be. And so I went into about 5 months worth of treatment of immunotherapy every 3 weeks. And about 5 months later, I developed an allergic reaction to that drug. But at that point in time, my pictures on my PET scan were looking really good, and so good that they were confident that they could stop my treatment. And 3 years later, nothing had recurred. And this beginning of this year, my oncologist said, look, I tentatively think that you're in remission, which no one has ever seen before. And I just hope that that gives some comfort to some people who might be in a really dark place. It is possible, and you just got to, you know, hope for the best and fight the hardest you can, because it can happen. So that's kind of my journey very fast in a nutshell.
Thank you, Christine, and thank you very much for the work that you do. I know you're doing this across Australia in terms of talking about your story, and just to acknowledge your courage and bravery for doing that. We're incredibly grateful for you being with us tonight. So thanks very much.
No,
and I'm sure there'll be lots of questions for you a bit later on. And our next speaker is Dr. Jane Leong, who's the head of the Global Influenza Vaccines Portfolio at Seqirus, and She's going to be talking about the industry perspective on the National HPV vaccination program, focusing on some of the challenges. And, you know, Jane has a fascinating career because she's not only doing this, she's worked in the public sector as well, and as a general practitioner. She has a fellowship at the College of General Practice, but she's also done her Masters of Business Administration. Great idea for those of you who might be thinking about working in different aspects of the of medicine. And she's been really involved in the launch of Gardasil. Obviously, we'll be talking about that a lot tonight. Rototec and Zostavax vaccines on our national immunisation program, as well as the rollout of the H1N1 pandemic vaccine. So this is a time for Jane, both in terms of COVID, but obviously, as importantly, in terms of HPV. So Jane, thank you very much, and over to you.
Thank you very much, Rob, for the kind introduction. I'm going to try and share my screen, but the host has disabled the sharing. So if you can let me share my screen, that'd be really terrific. So the host disabled participant screen sharing, so I don't quite know how to undo that, or if the host needs to do that for me.
Yep, sorry, Jane, I'll do that. 1 second.
Thank you. Shall I share now? Nope, not yet.
Try it now.
Okay. It just says host is still disabled participant screen sharing.
Sorry, 1 second. I'll go back to the initial settings.
Okay. How are we going? Still not able to share.
So it's not allowing me to edit that since actually, oh, I got it now. There you go.
Okay, excellent. Can you see my screen, which is more important?
Yep.
Yep.
Excellent. All right. Well, thank you very much for the opportunity to present an industry perspective on the HPV immunization program, particularly the launch campaign and some of the thoughts that we had as an organization on how to create a campaign that's going to encourage people to come and get a vaccine. So many of you will remember that in late 2006, the federal government announced funding for the cervical cancer vaccine Gardasil for girls 12 to 26 years old. And there were actually two components to this program. One is a school-based program for girls 12 to 18 years and above. And the other one is actually a GP-based program for young women 18 to 26 years of age over a 2-year period. So we had a very good relationship and working relationship with government, and we agreed that government would focus on the school-based program, a promotional campaign for the school-based program, and that our company would be focused on the promotional campaign for the GP-based program. So we went away to understand how best to do this. The challenge is that trying to get young women of 18 to 26 to come and see their GPs 3 times in a period of 6 months within a 2-year period, because the program ran only for 2 years. So we did some market research to understand better what are some of the things that would interest this particular cohort who do not visit their doctors regularly, who think that cancer is something that affects older people. Health prevention is not a high priority, very busy social life, very influenced by their peers, and they're the greatest targets for advertising. So it's a very noisy landscape that we're trying to cut through. We realized that motivating this group to go and see their doctor for a vaccine will require something quite different. And part of that difference is to make this issue something that they have to act on quickly, because we only had a 2-year period and we're trying to get many people in to see their GPs. So we sort of came down to 2 kinds of options. One was what we call the rational approach, which is to sort of link HPV to cancer and tell them how important it is to get a vaccine. The other one is more of an emotional approach, where we're telling them that they can be part of a generation who can prevent cervical cancer. So we tested both messages. So here's some of the testing some of the results of the testing. So first is the rational message, as I said, where we say cervical cancer is caused by HPV. And the participants in the market research were shocked that this was the case. It wasn't very well known, but it did change the attitude that this was something that was relevant to them and they could actually control it. But it also led to some questions and excuses. For example, I've been with my boyfriend for over a year. It might be too late. I don't think he's got it. I always use a condom. I don't need the vaccine. So the bottom line was that the link was important. It was found to be shocking and motivating, but it did lead to questions and excuses. So we looked at the emotional message, which was be part of the first generation, not to suffer from cervical cancer. And this was actually quite an emotionally appealing message. It gave a sense of empowerment and also a bit of feeling an obligation to act now. And talking about the generation was great because it gave people relevance to themselves. And also it made it a privilege because this was an opportunity that no one's had before. And because we talked about this is what people did in this generation, it normalized vaccination as well. So the overall feel from this market research was that this was a powerful and emotional message, which says that there is hope. So this was the campaign that we came out with our agency. And many of you may remember these posters. This is in 2007 now, so it's a long time ago. But it was really a series of black and white photographs of women whom we call in the right age group, so 18 to 26. We call them the everyday women. And there was a student, a waitress, and sort of people, sort of jobs that young women would do. But we also had a couple of better known faces. One is Gian Rooney. If you look at the picture on the left, that's Gian, and she was an Olympian, still is an Olympian. And we also had another lady whose picture is in here. Her name was Tanya Major, and she was Young Australian of the Year. She was a very strong Indigenous advocate. So there were some better known faces, but they were not the traditional celebrities from the entertainment field because they were not seen as credible advocates. So if you look at the photographs, each woman had a badge of honor on her arm in the form of an ID band-aid, symbolizing that she had been vaccinated. And if you look at the kind of the campaign, it was relatively simple. We didn't want to have too many things on it. There was a call to action, join the fight against cervical cancer. It gave the age group and it told them where to get their vaccine. So quite simple messages. And if you look at the right corner, there's a guard against cervical cancer, and the I and the CAN have been highlighted. So in a sense, this was what we call the I CAN campaign. But because of the band-aids, which are actually really popular, which surprised us, it also became the I DID campaign. And the advertising that was done sort of normalized vaccination for women of this age. So it was really quite an encouraging, empowering kind of ad. And what was really nice is that because we work closely with government, it actually was very complementary with the campaign that the federal government ran for the school program. So here you see a picture of mother and daughter, and we're talking about good news about cancer and how girls will be getting their vaccines through schools. So both campaigns were really very positive, very successful, and we actually had really good uptake in both schools and in the GP clinics. So I'm going to stop here. I think there'll be time for questions, unless there are questions that people want to ask now. I'm happy to hand over to the next speaker, Rob.
Lovely. Thanks very much, Jane. Fascinating and there's already a question. We'll come back to that really about how long this all took. So I'll just move on now to Tim Ross. And maybe you want to stop sharing, Jane. And Tim, I love Tim's purpose is for populations to live their best lives through innovative solutions for our health system. Tim has 20 years experience as a GP, so both Jane and Tim originally as general practitioners. Then Tim moved to Bupa in health insurance, health services and aged care, and now he's working with Telstra Health as the Medical Operations Director for the National Cancer Screening Register at Telstra Health, where he leads the operations including data quality, laboratory engagement, clinical safety, contact centre, mailhouse and data processing. Sounds like you'd be good for the pandemic as well, Tim. So over to you, Tim.
Thanks very much, Rob, and thanks everyone for the opportunity to share our story. great hearing from Jane, because I'm actually in the last 2 weeks of my MBA. So there you go. There's a bit of a common theme for all the students out there. There's a bit of a thread when you go into the corporate world. So yes, just writing my last 2 assignments. But this is a fantastic journey. I came into the register 2 years ago, so I was sort of given the head start of the hard work done by state and territory registers over many years, and having been one of the original screeners in general practice. But the movement from what was the pap smear to the HPV program was quite a seminal event, I think, in how we manage the risk of cervical cancer in this country. And just an incredible experience. Now, for the patient, they don't really see much difference. They go to the doctor, and for now, it's the same procedure for them. It's still a speculum examination and all the issues that come with that. However, the test is so much simpler to do now, and we're finding better ways to do that. There was that movement from a 2-year screening program to a 5-year screening program. Or actually, I think it was 3 years even. I worked in the UK as well, so it varied. Where it was 3 years over there and 2 years here, so I used to get mixed up with the two. But stretching out to 5 years, fantastic. Not as invasive of people's time or their personal space. Obviously harder to remember screening there. So it's really important that we have robust recall systems and a safety net, which is what our screening program provides by having a register underlying it. So previously, cervical screening, obviously the aim of this is to have early identification of risk for people, so that we can follow them up in an appropriate manner and hopefully prevent occurrences. You know, amazing to hear your story, Christine, and you know, just fabulous to see where you are now. But that's something we don't want anyone to go through in future. And as Jane said, you know, the first generation without cervical cancer would be just something world leading for us to do. So really exciting. So it was a lot of work. It's a 5-year screening program. We haven't got to 5 years yet. No one's gone back for their second test after a negative result yet. We really only started with the new program in 2017, so we've still got over another 12 months before we actually get to a full cycle of screening in terms of everyone involved. So previously we had 8 states and territories supporting screening through their registers. So you can imagine it was quite a big piece of data work to bring all those people into one national register. And, you know, there's no secret in the media, there was a lot of teething difficulties for the register. And even when I arrived 2 years ago, there was a lot of work to do, and we're still really working hard to bring that together. So we've got about 11 million records that came across into one single database. And I know this is about cervical screening tonight, but since the BOWER program came over as well from the Department of Human Services about 18 months or nearly 2 years ago now, it means that for women over 50, they've got one record with all their screening showing up on that. So fantastic way to combine records, people who've lived in different states and might have had records in different states. That all sits in the one record now, and we're able to invite and remind people to screen using Medicare details as our primary source, and provide that safety net to get into screening. So of course, screening involves everyone. It's the participants in the community. We call them participants. It's the patients. We work with healthcare providers. We work with the state and territory governments, and we work with reporting people. So the Australian Institute of Health and Welfare, we provide analysis and reporting to them, so that can inform screening and how the program will move forward in the future. We haven't got a baseline yet. It's called the renewal program, because of course we've renewed from going from a PAP test to the HPV test, but renewal is still renewing. So looking for patterns of screening over the 5 years, the number of positive HPV results, which then leads to what we call a second test, or the LBC, which is liquid-based cytology. So where we used to take a sample of cells off the cervix in the old PAP test, that is still done in the current test with the GP. It's just that we only test for the HPV, which is a very simple laboratory procedure. If that's positive, we can then run the cells through as well and do a correlation to see what the risk profile is. So that's the main change in the test, because of course the majority of women have a negative test. All they have to have is the HPV run through the machine, and we don't have to spend any more laboratory time checking on the cells and the like. So we're still trying to get a baseline of what those results are. Of course, there's all the delights of COVID that have come along. Many of us are sitting here in lockdown for some of us have had 2 birthdays in lockdown. So that has changed the nature of screening in the last 18 months in terms of people's access to their healthcare providers, certainly for cervical screening, where it still does require usually a doctor or nurse to do that screen. So as I said, the experience for the individual at the moment is the same, even though the test is actually different. We get about 80,000 screening tests a month at the moment. That did drop as low as 30,000 a month in the depths of lockdown last year, but even now, we've just done our reporting for August, we had over 80,000 screening tests, which shows that I think people have settled into more of a lockdown cycle, so they're actually feeling more comfortable to go and see their healthcare provider and continue screening, which is really good. Of course, the next step, as Jane was talking about, is the vaccinated cohort. So that young cohort back 2007, 2008, they're all 25 and over now. So we're actually hitting the first group of the population who we should really see a change in how those results look as they come through. We should have a dramatic rise in the number of negative results. It is on the roadmap for the register to know people's vaccination status. Of course, we can do that because the Australian Immunisation Register registers anyone who's had an immunisation when it's done by the healthcare provider, whether that's at school or with their doctor. At the moment, we're not linked to the register with the immunisation registers, so we don't have that. And you know, my personal belief, and I know working with the health department and with the states and territories, we're all really keen to get that as soon as possible, because that will then be able to really relate that vaccination status with the drive in negative results, which will just be fantastic. As I said, at the moment, the worst thing about cervical screening is that it's time consuming, it's an intimate examination, it involves a third party. What's really exciting, and I think Marion's talking a bit more about the home base, but there has been because we only need a sample to test for the HPV presence, is you don't have to do an actual smear of the cervix. You can actually just take a sample from what we call the vaginal vault or high up in the vagina, which only needs the swab, not the whole speculum examination. And that can actually be done by an individual themselves with the right guidance. So I think that's going to be an absolute game changer in terms of participation rates and screening. And I'm sure Marion will have more to say on that. So I'll let her cover that in more detail. But that's probably the most exciting next step, along with vaccination, in terms of how we get women involved with their screening. I guess the only other thing is, yeah, with COVID, it's been a big change. Obviously, for everyone working, whether it's the use of telehealth, whether it's the ability to access the services we need, we've worked really hard. It's a fantastic arrangement, the way the states and territories work with the health department, the Commonwealth Health Department, and working with Telstra Health. There's just this continuous drive to improve and get participation, and events like this are a great opportunity to do so. So thanks for having me along tonight, and look forward to the discussion.
Great, thanks very much, Tim. Greatly appreciated. And talking about game changers, our next speaker is Marion Saville, who's going to be talking to us, as Tim mentioned, about what's happened through COVID. Just to introduce Marion, she's the Executive Director of the VCS Foundation, has been since 2000. She's a major and trusted advisor on cervical screening to governments here in New Zealand and Ontario, New Zealand, because she's in fact a New Zealand medical graduate. She's really been focusing on research and implementation projects demonstrating it's possible to deliver high quality, acceptable cervical screening in resource poor settings. And where that's been happening is in Malaysia, PNG, and Samoa. And very interested in how culturally safe screening can meet the needs of disadvantaged groups who have poorer cancer outcomes in Australia and New Zealand. So Marion, without ado, over to you, and thank you very much for being online tonight.
Thanks for the introduction, Rob, and I'd like to start by acknowledging that I'm coming to you from Wurundjeri country and pay respects to elders past, present and emerging, and any Aboriginal people joining us tonight. I'd like to thank Christine for her story. I've had a whole career about preventing the experience you've been through, so thank you for your, for being vulnerable enough to talk about some things that are pretty confronting. I think people need to hear it. And I suppose one of the things I was thinking when you talked about your presentation is that the thing that was bad for you is advanced cervix cancer is a rare disease in Australia, and it made the mindset of the doctors that saw you first not think of it. But unfortunately, it's not a rare disease globally. It's more than 500,000 women a year. In many countries, the second most common cause of cancer death. And half of the women who are diagnosed with cancer internationally die of that cancer. 87% of those deaths are in low and middle income countries. So the WHO has established and made a call for the elimination of cervix cancer as a public health problem. Just want to reinforce that elimination is not eradication, and that we'll probably always need for the foreseeable future ongoing prevention activities. And to say that the elimination target is an incidence of 4 per 100,000. Australia's incidence has been around 7 for a long time. Victoria, with a very good state-based register, excellent laboratories, great participation, has been bouncing around 4.8, 5.2. And our mortality at 1 per 100,000 is world leading. So we've had great programs, but we've had groups that have missed out. And many of my colleagues are very clear that Australia will probably be the first country in the world to reach this elimination target, and in fact was the first country in the world to have a nationally funded HPV vaccination program. And so when we were able to switch from pap smears to 5-yearly HPV tests on the 1st of December 2017, we were actually the third country in the world to do that. And so we are in many ways world leading. We do things differently. When we were having those policy discussions about the renewal of the cervical screening program, we knew we had this opportunity with self-collection. So you've all seen these swabs now because of COVID, but these are the swabs, and it's not actually a high vaginal swab, a vaginal swab will do. We've done a lot of projects with these swabs. When we looked at our policy, we had a 2014 meta-analysis that told us we were going to lose about 8% of sensitivity of the HPV test, and that would model into a loss of cancer prevention effectiveness if we went wholly over to self-collection. And that was based on old tests prior that were in the meta-analysis in 2014. So in that context, the Department of Health and the advisory committees wrestled with the trade-off between increasing the reach of the program because we knew it would be very acceptable versus losing some effectiveness. And we came up with this policy that has been very difficult for people to implement, where underscreened participants could access self-collection, but not everyone else. In the meantime, in 2018, we got new evidence with new generation tests based on PCR. Those tests we're all doing for COVID now, and we're doing about 1,000 tests a day at VCS for COVID. And that new evidence showed that provided you use a PCR-based test, you had exactly equivalent performance, sensitivity and specificity. And on that basis, the Medical Services Advisory Committee has made a recommendation to government that we make self-collection available to all Australians eligible for cervical screening at their choice. People who still want a speculum exam can still have that. And provided government accepts that recommendation and funds it, we could be looking at that potentially in less than a year. And the reason I'm excited about this is that in 20 years of trying to reach underscreened groups, everything we've done, community health promotion, writing letters of reminders, everything trying to drive these people to their GPs for a speculum exam has had a small incremental benefit. But in our acceptability pilots in Victoria, in an Aboriginal health service, in a community health service, and the Salvation Army down in St Kilda seeing street workers, we had the GPs there ask people who said no to a pap smear whether they would collect one of these. And in all three services, we got around 85% participation in the program. That's, to my mind, it doesn't answer every problem. It wasn't 100%, but to me, compared to we got it up from 24% to 28%, that's a breakthrough. in the reach of the program and the acceptability of the program. And so that's really exciting. The WHO call has a strategy where we're to screen 70% of age-eligible women globally between the ages of 30 and 49 by 2030, twice, 10 years apart. That's billions of women. We are not going to reach them with a speculum. So there are two advantages to this swab. One, acceptability, overcoming cultural barriers as we saw in Malaysia. Women who would not have a PAP collected this swab. But two, scalability and how much less it asks of health workers that are stressed in fragile health systems. So I am very excited that self-collection will be the thing that sees us through to when the children who've been vaccinated with the 9-valent vaccine come through to our screening program, which is over a decade away. Tim, to your point about vaccination, the oldest cohorts that were often publicly funded 4-valent vaccine are now 40. And we have seen a complete flattening of the age prevalence of the vaccine preventable types. So we published that from our lab. Typically, the prevalence of the types we look for in the screening test that cause cancer are very age-related. We almost all get an HPV infection early in the years when we start having sex, and that declines with age and settles down. We still have that pattern in Australia, except that the HPV 16 and 18 is a flat line across all ages at 2%, which is fantastic because that's 70% of cancer. But when the 9-valent comes along, we'll see that flattening of prevalence in the younger age group for the other types that are causing a lot of, still have the potential to cause cancer and a lot of screening activity. I think when those groups come through, for those cohorts, they might only need 2 screens in a lifetime. And eventually this will be a completely vaccine-prevented disease. Whether or not we can eradicate this virus through vaccination is a question for generations behind me. It won't happen in the next several decades, but that's where we're going. And how exciting to have a cancer that we can almost entirely prevent if we get the right services to the right people and the education right. We don't want people to go through what Christine has been through. And sadly, it's incredibly common in our nearest neighbour, Papua New Guinea, 30 per 100,000. That means it's the same pretty much ballpark of breast cancer incidence. Everyone knows someone who's had this cancer. Think about that. You don't know much about cervix cancer because we've made it uncommon. And this inequity is about access to preventative services through vaccination and screening. And I'll stop there.
Lovely. Thanks very much, Marianne. It is very exciting. There's also a film called Concrete Cancer about the elimination of cervical cancer, which has been produced locally. And we're hoping that we'll be able to bring that to you live in the near future. So thanks very much, Marianne. And now to introduce our last speaker to cap the program off, Setyana Marta Dewey, who's a sexual and reproductive health specialist practitioner with 12 years of experience in Indonesia for female sex workers, street youth, LGBTQI youth, and school-based adolescents. We're very fortunate that Dewi is she's chosen University of Melbourne to do her PhD, and she's working on how school-based HPV immunisation programs in Indonesia can be maximised as a health asset to promote cervical cancer prevention and sexual and reproductive health. So Dewi, over to you, and thank you very much.
Thank you, Rob, and thank you everyone for the refreshing presentation. I would like to share my screen. So let's see if I can do that. Oh. 1 second. Sorry, a little bit of technical difficulties.
So have you got permission to show your screen? Yeah, great.
Yeah.
Yeah, we can see it now. That's great.
Okay, sorry, it took some time. Before I start, I would like to acknowledge the Wurundjeri people of Kulin Nations as the owners of the land where I live and work, and pay my respect to the elders past, present, and emerging. As a little bit of background, my PhD study focuses on understanding potential avenues for increasing knowledge about cervical cancer prevention within family and community setting, and the upscaling of HPV vaccination introduction program to a national childhood immunization program in Indonesia. But for today, I will briefly discuss current challenges in HPV vaccination program in Indonesia and potential assets to promoting HPV vaccination. To give you brief context about challenges in cervical cancer prevention in Indonesia, we have very high cervical cancer mortality and morbidity. So about 2 women die every hour in Indonesia because of cervical cancer. And this is partly due to the fact that free cervical cancer screening is only offered to married women between the age of 30 to 50 years old. And the fact that school-based HPV vaccination is only recently introduced in 5 out of 34 provinces. And currently in Indonesia, we have no strategy to cover out-of-school girls. And in addition to that, there is very low awareness of cervical cancer prevention among women and girls, and this is associated with low participation in early detection, which often result in late cervical cancer diagnosis. And recent studies in Indonesia have shown that about 1 in 5 women are aware of cervical cancer screening, and those who are aware of cervical cancer screenings and HPV vaccination usually are women with higher education and higher income. And so regarding HPV vaccination, there is generally high coverage within the introduction program, but there are persistent concerns regarding HPV vaccine cost, safety, and halal status. And this contributes to vaccine hesitancy among parents and girls, especially those outside of the introduction program. And so in my PhD, one of my area of interest is exploring how mother-daughter relationships can be a culturally safe environment for communicating cervical cancer prevention, and how it can be an asset for a future HPV vaccination strategy. Studies conducted in Indonesia have found that parental support is an important determinant in HPV vaccination, and especially mothers or female caregivers play a significant role than fathers in socializing their daughters about sexual and reproductive health. We also know that better knowledge about cervical cancer and HPV vaccination among parents and girls can lead to higher HPV vaccination acceptance. Now, in regards to HPV vaccine halal status, in majority Muslim communities such as Indonesia, religious leaders can be instrumental in assuring parents on the halal status and safety of HPV vaccines. And while the effectiveness of this strategy remains to be seen, engaging religious leaders or community leaders can potentially be a good thing, as long as they receive training and are well informed about the benefits and limitations of the vaccines. And so to tie this all back to Australia, I looked at the impact evaluation report for Australian National HPV Vaccination Program from NCRIS. And one of the recommendations suggests developing information and educational materials for parents and adolescents in multicultural communities. And so I believe that this strategy can be enhanced by identifying culturally safe space for families to discuss HPV vaccination. In Indonesia case, it's potentially mother-daughter relationship, and also identifying accessible ways for members of multicultural community to discuss vaccine concern and intention, be it through religious or community leaders. So that's the end of my presentation, and thank you for listening.
Oh, wonderful, Zoe. Thank you very much, and good luck with your PhD.
Thank you.
And now we're open up for questions, and I'll actually throw it to Moira, who's going to take you through some of the questions, and particularly those ones that have been, in a sense, valued as well. So over to you, Moira. Thanks.
Thanks very much, Rob, and thanks everyone. Your presentations and speeches have been absolutely incredible. So the most upvoted question at the moment is for Christine. So from a patient perspective, what particular impacts do you think COVID-19 lockdowns could have on care?
I think it's very detrimental. For a person like me, I think that had I been going through, or had I been at the stage I was at when I access the immunotherapy, if I was at that stage going through lockdown and going through COVID, I don't think I'd be alive today, because I was so lucky to have an amazing support system around me who not only could take me to appointments, but could look after me when I was told by palliative care that I could not be on my own with my daughter, because I would, get intestines hooked up on my scar tissue and would have to be carted off to the emergency room in the middle of the night. And obviously, if my husband was at work, I had to have someone there. Now, if I had been in lockdown and they were in lockdown, there's no way I could just get someone to come into me, or if we were in different local government areas and you were having to move from one lockdown area to a non-lockdown area. So it would have been extremely detrimental to my treatment and my mental well-being as well, in coping with the diagnosis and coping with just living day to day, and things that you never think you'll have to do, like plan your own funeral, but you have to do those things. You can't kind of leave it. A support system around you and not feeling that you're alone, but you're supported in every which way, that helped me. And for those people who are sitting alone with it, it's just awful, and I feel just heartbroken for them. So yeah.
Thanks for that. I'll pass on to Sophie now for the next question.
So the second most popular question is, how are refugees included in Australia's vaccine program, and how do they catch up if they don't receive or have missed a vaccination? So that's more of a question open to the panel. Anyone in particular want to take that question?
Yeah. Here in Victoria, the government runs specific programs to help catch up refugees and asylum seekers. And at VCS, we used to run the Victorian and South Australian cervical screening registers. We updated that technology, and we actually use a specific piece of technology to help the department with tracking catch-up vaccinations for people who have missed out of their vaccinations because they're not on Medicare. And we built a bit of extra functionality to link together family groups in that program of works. It's had various names. It used to be called Providing Immunisation to Vulnerable Groups. And there's also now some provision out to some kids who are living on the streets as well. So there are people our programs don't reach who are outside the Medicare program, and that vulnerability needs a special thought and services. And the other thing I'd say to this particular audience, not knowing how old everyone is that you can get free catch-up HPV vaccination through your GP to the age of 19 these days. And we do hear of people whose parents didn't let them have it or they missed doses at school. And that does allow young adults to make their own decisions, although always better pre-adolescent than older, but that is available too.
Fantastic. Great to hear that there's real programs in place to address that. I'm just going to pass the next question to Mason.
Thanks for that, Soph. So this question is directed at you, Jane. So how long did it take to test out all like the campaign messaging from generating the ideas to like results?
Well, we got the announcement in November of 2006 and the program started in July 2007. So it was pretty much a 6-month project where we had to get it all done and kind of tested and rolled out ahead of the program starting. So it was pretty tight timelines. I remember that it was super busy. I think we worked pretty much day and night just to get it moving. But and we had to make sure that it was all compliant and all the right sort of legal sort of considerations. So it was pretty tight, but it was, from memory, super exciting at that time.
Thanks for that. And I'll just pass a question to Maz.
Hello. So this question is open to the panel. So what do you think that the impact of COVID and the resulting homeschooling and telehealth has been on the vaccination program? And what do you forecast as the ongoing impact if there's been a reduction in vaccine rates?
Well, I'm happy to take that one, especially given I have a Year 7 this year who has been impacted by homeschooling, or maybe we've been more impacted by his homeschooling. I think a lot of the schools have made arrangements where they're closed, either with the local councils and students have been able to access vaccines there, or with their GPs. I think another advantage is the program targets Year 7s, where the risk is lower in terms of probably the majority of that age group have not really entered too much sexual activity. So even with, I mean, last year we thought this year would be open, but even if your vaccination is delayed by maybe 6 to 12 months, the impact of that upon the future is probably very low. I think the risk is low, but the schools have been really good at working around that to give their students every opportunity of having both doses. And certainly my son was able to get both of his, one at school earlier in the year and one at the local council a few weeks ago. So yeah, a really good cooperative effort there.
If I can add to the discussion, one of the things that we do see is also vaccination of international students. And because we haven't had, got international students, we see that not being a big part of what we would usually provide, which is rather sad because in many countries, this speaks to some of your work, Davy, is that they simply either cannot get vaccines or not encouraged to. When we see that when they come to Australia to go to university, we see that they take the opportunity to get vaccinated, which is very positive. But because they haven't been around, we haven't seen that much. But I think that would be an important part of public health for them.
Thank you. I might also ask another question from Marion. So are women offered swab screening in early pregnancy or post-pregnancy? GBS screening is offered at approximately 36 to 40. Could it be acceptable to offer it then as well?
So, so screening should be done in pregnancy if the woman is due or overdue for screening. It shouldn't just be a routine part of antenatal care for everyone, and particularly not people who've had a recent negative. It's very interesting that the Australian model of self-collection that we settled on actually came out of advice from a GP working in Central Australia, where self-collected swabs are very commonly used for STI detection and in pregnancy. So around the rest of the world, self-collection is through the mail, and you don't get nearly the response rate through the mail as you get when a swab is handed over the consultation desk from a trusted provider. So the short answer is yes, you can screen in pregnancy. You can do it with a speculum exam the usual way. The swab is perfectly safe and more likely to be acceptable. but you don't routinely screen everyone because they're pregnant. You ask them in pregnancy when their last screen was, and you screen them if they're due or overdue.
Fantastic. So we'll have another question now for Tim. So this is from Chris. So you didn't quite catch how do you get the information, so the results information from laboratories or from the sources to the register, and what kind of problems could arise from that? Also, has there been a measurable change in the progression of disease at screening during COVID? Sorry, Tim, did you catch that one?
Sorry, I just got disconnected briefly, so if anything came my way, I missed it.
No worries. So we just had a question from Chris, which was, how do you get the results, so the result information from the laboratories to the register, and what are the problems that arise from that process?
That's a really good question. It's actually fantastic. There's, for any of you who've done any health informatics, there's a thing called HL7 messaging, which is health level 7 messaging. So it's actually electronically. So all the labs are actually mandated in the cervical program to send all CST results to the National Cancer Screening Register, and they're reconciled monthly. We have a lab engagement team who works very closely with the labs to make sure that the tests are coming in a timely fashion. We're able to record them. So super efficient, no faxes, no pieces of paper, no confusion. There's a thing we call the Provider Integration Guide, which I love to call the PIG, which gives all the sort of rules and regulations around how that information is provided to us, so we know which lab it's come from, which provider did it, who ordered it, who actually did the test. Really good, useful information.
Great to hear that it's so streamlined. Actually, a question for Setiani. Can you elaborate on what you mean by mother and daughter influences and how it encourages women to take the vaccine?
Yeah, I mean, I'm still in the process of collecting data, and so I'm actually interested to see what comes out of the data later. But what I mean by mother-daughter relationship is that, like I said, in Indonesian context, especially, mothers or female caregivers are seen, or they're the primary source of knowledge for sexual and reproductive health for their daughters, especially in family setting. And so there has been studies that indicate that intergenerational transmission of knowledge around cervical cancer from mothers to daughters or daughters to mothers can be a good thing for cervical cancer prevention. And so in my study, I'm interested to explore whether this is a potential avenues to promote HPV, not only HPV vaccination, but also early detection for cervical cancer. So I hope that answered the questions.
Thanks for that. Just the last question for the night, just wrap it up. So this is a question from Kevin. So this is a question for all the panel. Screening and preventative measures are always difficult to be accepted by migrants and CALD communities. What strategies do you think would benefit acceptance, reduce hesitancy, and improve uptake? And he says, thanks for the discussion so far.
Well, look, I'm happy to kick off. And in relation, I'll talk about screening. I'll leave vaccination to others. In relation to screening, we have found that there are barriers to screening depending on who you are, where you live, and whether you're socioeconomically advantaged. But one of the things about who you are is that for a range of cultural groups, pelvic examination with a speculum is not acceptable, and self-collection is great. So that's the high-level principle. Then there's a whole lot of work that has to be happen at a community level, community by community, and I would say ideally a co-designed process where we educate communities about cervical cancer in partnership with people from those communities, and we make the screening available. But the implementation science side of things, which is something I've only been involved in for about five years or so, is really, really important, and engaging with the communities that you're trying to reach is critical. We can't do things to people. We have to do things with people. I think what to do to reach these WHO targets and to address inequity is pretty clear, that self-collection is going to be a great way to go, but how to do it is different in every community, and we need to listen to the communities.
Right. Okay, we might wrap up there, and just I'd like to thank our terrific speakers, Christine, Jane, Tim, Marion, and Dewi. We really appreciate the time you've spent with us. And I'd also actually like to thank the Student Society. I mean, I congratulate you guys for all the work you've done. Carl, Zainab, Maria, Mason, Maura, and Sophie. Really great for this for you guys to put this together. As we said before, we'll make sure that you get access to the Conquering Cancer film, which has won several awards already. We look forward to seeing you then. But again, thank you so much to all our speakers.
You're very welcome. Thanks.
Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.